Patient Safety and Quality Clinical Excellence Queensland has developed a podcast series for Queensland Health staff and Hospital and Health Board members to hear from guest speakers on topics relevant to safety and quality in short bite-sized segments. All episodes are recorded on the lands of the Yagara and Turrbal people. We respectfully acknowledge them as the traditional custodians of Meanjin and pay respects to the elders past, present and emerging.
Hello and welcome to another episode in Patient Safety and Quality's podcast series. My name's Melleesa Cowie and I'm a Director at the Patient Safety and Quality Clinical Excellence Queensland. And in this episode, we're going to be talking about coronial management, including the role of the coroner and how it applies in the context of Queensland health. And with me today is Coroner Megan Fairweather, who is the coroner for Brisbane. Hello and welcome, Coroner Fairweather. It's great to have you join me today.
Hi Melleesa, thank you for that introduction and I'm really happy to be here. I'm actually just one of the Brisbane coroners. There are a number of us, but I'm very proud to be one of the coroners in the Brisbane court.
Thank you. And to begin with, I was thinking we might start at the beginning and I'll ask you to just tell us a little bit about the Coroner's Court in Queensland, its functions and in particular the role of the coroner.
Well, in a nutshell, the Coroner's Court of Queensland works closely with the Queensland Police Service and Queensland Health to provide Queenslanders with a consistent and coordinated system to investigate certain defined reportable deaths under the Coroners Act of 2003. These include sudden or unexpected deaths, deaths that occur in custody or in care, or deaths that happen in police operations. Not all deaths are reportable, and not all deaths require an inquest to be held. When a death is reported, the coroner must investigate and make findings where possible about the identity of the person who's died, when and where they died, how they died, and by that we look into the circumstances and the context around the person's life immediately before their death, and then the medical cause of death. A coroner is an appointed magistrate who is responsible for investigating coronial deaths. An investigation can help provide answers to families about what happened to their loved one. And in some cases where systemic issues are found to have contributed to the death or important public safety issues come to light during the investigation, the results can inform the community about death prevention ultimately.
Okay, so you talked there about reportable deaths. What is a reportable death and who reports them?
Well, I'll go to the legal bit. A reportable death is defined in the Coroners Act under Section 8, and they include deaths that are violent or otherwise unnatural, and that is the main body of work that we do. I think more than 50% of the matters that get reported in are in that category. Other categories include the death happened in suspicious circumstances, the death was a healthcare-related death, and we will talk a bit more about those deaths soon. The death occurred in care or in custody, as I mentioned before, or as a result of police operations. The identity of the person is unknown is another category. And finally, there's a special category for a cause of death certificate can't be issued or is not likely to be issued for the person, and so it requires an investigation by the coroner. As a general rule, anyone who becomes aware of a defined reportable death must report it either to a coroner or to the police, unless there's a good reason to believe that someone else has already made the report. There is an exception to this. If the death happens in care, the service provider must report that death, even if they believe someone else already has. And I think it's important to mention as well that a failure to report a death is an offence under the Act, and it can result in penalties for someone who doesn't make a report.
Good to know. Thank you. One of the categories you talked about there was a healthcare-related death, and I'm keen to narrow in on that one a little bit more. What is a healthcare-related death and when is that reported?
Would it help for me to explain the definitions
that
are
please.
under the Act in the
Please
first
do
place? So healthcare is defined in the Act as a health procedure or any care, treatment, advice, service or goods provided for the benefit of human health. And a health procedure is separately defined as well to include any dental, medical, surgical, diagnostic or other health-related procedure, including a consultation or the giving of an anaesthetic or other drug. So it's a very broad remit for the coroners, and healthcare-related deaths do happen. A healthcare-related death under the Act has two key elements. One, that there is a causal link of some kind between the healthcare provided or not provided and the death. And secondly, that the death was not reasonably expected at the time the care was being sought by the patient. And for people who want to look things up in legislation, that's section 10, double capital A of the Coroners Act. Some practical examples of this might be where there's been a failure to provide a referral for specialist input into someone's care, performing the incorrect procedure on a patient, or that there's been unexpected complications arising in a routine surgical procedure, for example.
Yeah. So it sounds simple, and maybe that's again because it is, as you were saying, it's quite broad. But I imagine in reality it's quite a complex, process to go through in your own mind. Have you got any tips for someone who might be trying to establish if the death was healthcare related? I'm thinking, what are the sorts of questions I should be asking myself to try to come to that decision myself? Any thoughts?
Yes, for sure. It is tricky. And in my dream, there'll be an algorithm that we can add into the IEMR at some point to help doctors and others through a step-by-step process to come to an answer at the end, is this death reportable or not? I can answer that in two parts by reference to each element of a reportable healthcare death. So firstly, to work out if the healthcare caused or contributed to the death, it might be helpful to ask these three questions. 1, did the death result directly from an underlying disease or injury? Would the person have died at about the same time, but for irrespective of the healthcare being provided or not provided? And was the healthcare carried out with all reasonable care and skill? And if the answer to any of those three questions is no, the death is reportable under this category. Conversely, if the answer is yes to these questions, it won't be reportable and things can move on without the coroner's involvement. Secondly, to work out if a death was not reasonably expected, consider what a professional peer of the treating clinician would think about that person's prognosis before the healthcare was provided or not provided. And in that category, it might be helpful to ask, was the person's condition such that death was more likely than not to occur before the involvement of the healthcare? Was the person themselves aware that their death was more likely than not to occur before the healthcare? And was the decision to provide healthcare reasonable given the person's condition at the time, including the quality of their life if the healthcare was not offered to them at the time? And again, if no to any of these questions, then the death is reportable under the Act. And if the answer is yes to all of those questions, then it's okay to move on without the coroner's involvement. So in summary, the main thing to reflect on the person's condition at the time of presentation and thoughts about their injuries or underlying disease, and then their risk profile for the healthcare that's being offered to them.
Okay. So what are some of the common healthcare-related death scenarios that you see as a Brisbane coroner?
Well, it's probably not a surprise to mention that coroners continue to see surgical mishaps, failures to diagnose or delays in treating life-threatening illnesses and conditions, lack of communication between healthcare providers, including with GPs and other specialists. Medication mistakes still happen. Over-sedated patients in ED seems to be a bit of a theme of late as well. We can see equipment failures during surgical procedures. Neonatal deaths still occur from prolonged labours and not recognising fetal distress. And we still see mental health death, failing to monitor someone who should be on close observation.
Yeah. There's lots of things to consider, isn't there, as you're sort of working this through in your mind. And we're all humans and no doubt we get it wrong on some occasions. Are there any scenarios that, you see that trip us up or maybe, more confusing than others that you see come across your program? And I'm just thinking, any scenarios in particular where you see that we're clearly needing some more direction?
I should mention the Coronial guidelines, which are on the internet. They've been around for a very long time. They probably need a bit of an update, but they're still really comprehensive and relevant for people who want some more guidance. And there's multiple examples, I think, in Chapter 3 of the Coronial guidelines to help kind of juxtapose what's reportable and what's not.
Yeah.
I think the element of being reasonably satisfied whether the death was expected or not expected is the main thing that can trip people up. We coroners grapple with these questions as well. It's not always easy. If I provide an example of an expected death where an elderly patient with multiple cardiovascular or respiratory comorbidities dies following surgery, that's being performed to excise a late-stage lung cancer, for example, we would expect that her prognosis is, say,
Yes.
very short-lived.
Yes.
If the lump is not removed, then we would expect the consenting process would discuss that with the patient and the family, and that the risk of surgery not working out being part of that discussion would be well and truly covered.
Yes.
And in that case, it would be a not reportable death, unless there's some problem with this surgery itself, of course.
Sure.
And that's where, it does get, you can go around in circles with these things. But another area that can be confounding, in my experience, are out-of-hospital cardiac arrests, where the patient is revived by paramedics on the scene somewhere but die soon after they arrive in the hospital. This can also be quite tricky. If the cause of the arrest is known to the treating team and it's expected because of their known underlying natural disease, then it's not reportable. Sure. If the cause of arrest is not known, for example, a 40-year-old fit young person who has no known medical history, then that would not be expected, and a cause of death certificate is unlikely to be issued in that case. And in that sense, we'd need some help from our forensic pathologists probably, and so it would be a reportable death.
That makes sense, yep.
And another anomaly, so we have a coronial registrar system, which I'll talk about a bit later, but I went to the registrars this morning to say, do you have any anomalies that cause confusion out there in the community, in our medical community? And she said on our death reporting forms, there's a box to tick that says, has the person had surgery in the last 4 weeks? And she wants everybody to know that statistical information for the ABS. It's not a coronial question for whether or not the death is reportable. Mm-hmm. So the advice is to always go back to basics. Was the healthcare relevant in some way to the cause or contribution to the person's death? And if the answer's yes, it's reportable. If the answer's no, it's not. Yeah,
that's good advice, because I have heard that one as well. So thanks for clarifying that. It's good advice. But yeah, it can still be quite complex, can't it? I can see, how people grapple with this. Might be 2:00 in the morning, and it's been a complex care that's been provided to patients. What can clinicians do if they're still in doubt? They've gone through those questions, they've considered that, but they've still got this doubt in their mind. What options are available to them for some assistance?
I think in the first place, which is what I still do when I've got a complex legal question that I'm grappling with, speak to a trusted colleague, hear yourself say it out loud, because often just by having a conversation you'll land at the right answer.
Yeah. True.
Or a senior administrator at the hospital, someone who's had experience in the coronial environment. Failing that, we have a fantastic team of coronial registrars who are available during office hours to workshop questions. They are our court's triage hub and help to resolve multiple contacts every day from our primary health sector. So they have significant expertise. Their contacts, if you need them, are easily found on our court's website in the health professional information section. We also have a coroner who is on call 24/7. We take that in turns to receive those calls in the middle of the night when needed. In most cases, in our experience, a call can wait for the registrars, but we understand it's sometimes necessary to make that call in the middle of the night, particularly where approvals are required for organ donation or sperm retrieval. Can I say here as well, it's really important that the person who makes the call is a person who has sufficient knowledge of the matter. Don't get the most junior person who came in the last 5 minutes to call the coroner. That's not fair to either the junior person or the coroner, because we won't get the right information to help make that decision about reportability. It's also crucial to just punch in a reminder here as well, not to release a body to a funeral director when a decision is pending about whether a death is reportable, or if we're still grappling with that, because the coroner owns the body, in quotes, at that point, and until the coroner's approval is provided, the body can't be released. And our website has lots of information about dealing with a deceased person's body as well, if there are any other questions about that.
Okay, so we've determined that a healthcare-related death has occurred and that it needs to be reported to the coroner. How does that happen? What's the process we follow to do that?
Well, it's really, really easy. You can go straight to Google and type in the words Form 1, capital A, and the form will pop up with instructions on how to complete the form and when to use it. It's really straightforward.
Good old Google.
Good old
Google.
Google. And I'm sure there's information on Queensland Health's intranet as well on the QEPs. But a Form 1A can be used by a medical practitioner, and can only be used by a medical practitioner, I should say, to seek advice to the coroner about whether a death is reportable. So that's actually another way of resolving that question if there are questions about it. But also a medical practitioner can use a Form 1A when the death is apparently reportable, or it seems to be reportable as defined under the Act, and the medical practitioner wants the coroner's authorisation to issue a death certificate. And a medical practitioner might do that when the cause of death is absolutely clear and obvious, and that there's no necessity for an autopsy or other investigation to resolve that part of the question of the coroner's function, which is to determine the cause of death. When a Form 1A is used by a medical practitioner, it's really important to supply supporting documents to help the coroner work that out, or the coroner's registrar usually would work that question out. So forwarding on the discharge summary, recent admission notes, a draft of the cause of death certificate, that will also assist the coroner too.
So that actually raises a question for me around the supply of information. Clearly, one of the responsibilities we have in the healthcare system is to assist the coroner do their investigations through providing information. And it just makes me wonder around the confidentiality side of providing information. As clinicians, we're very aware of the need to maintain confidentiality in the records we produce. Can you talk to us just a little bit about, confidentiality and what can be provided and supported through the Hospital and Health Boards Act?
Yeah, that's a great question, Melleesa. I mean, fundamentally, we know that health information is the most precious information to a person, and it is bound up in lots of detailed confidentiality and privacy law. And so without wanting to give legal advice, I'm aware that there are exceptions to the usual obligation to maintain confidentiality under the Hospital and Health Boards Act if disclosure is made to a person who is performing functions under the Coroners Act. But if there are any concerns or questions about that, then I encourage people to go to their own legal team or information access teams to resolve any questions they might have about disclosing health information. And then from our side as coroners, once a death is in our jurisdiction, we can require information to be given to us. And usually my practice in a healthcare related death, of course, I want to see medical records, any other notes. Often I'll ask for a statement from the doctors and nurses who've been involved in the person's care. And sometimes we ask for administrators to give us statements as well to explain what are the systems and policies that the hospital puts in place to support their clinicians in providing the healthcare. So it's really important that this information is provided to the coroner as soon as possible. We do like to get through our work as quickly as we can. Obviously, health investigations tend to take a bit longer than some of our other matters. So the sooner information comes in, the sooner we can get on with resolving our questions.
Which is totally understandable. I'm going to digress just for a little bit because I've heard, and in this space you hear a lot of different terminology, and maybe I should have asked this earlier, terms like coronial investigation, inquests, non-inquests. Can you just tell us a little bit about what those terms mean and what any of the key differences are? I know I've fallen in the trap potentially in the past around using them interchangeably and not really understanding what the difference between those terms mean.
Yeah, for sure. So whatever terminology is used, the coroner has the same statutory objectives for all processes for inquests, non-inquest investigations. That is to make findings about the identity of the person, when, where and how they died, and the medical cause of death. In most cases, the coroner will ask for a post-mortem examination to be done by a forensic pathologist for guidance about the medical cause of death, to tick that section off. This might be an external examination using CT and medical documents, or the pathologist can perform invasive internal autopsy procedures or limited internal autopsy procedures. We can direct the pathologists to use an element of their discretion to investigate to the extent necessary to establish the cause of death. So all reportable deaths become a coronial investigation, essentially. in a nutshell. A coronial investigation is conducted behind the scenes. That's where we'll ask for documents, ask for statements, get policies and procedures, and try and understand the system in which, in our case here, healthcare is being provided. That all happens behind the scenes, and the majority of deaths that come through the door are resolved and finalised by a quiet investigation.
Yeah. Yep.
At the end, the coroner will write a decision about the death and make findings, the compulsory findings, as well as, provide some context around the person and their history in making those findings. And then those findings will be offered to the family members and any other interested parties. So if it was healthcare, the doctors and the hospital system might get a copy as well. A coronial inquest is a separate process that happens when an investigation can't be finalised without more. The coroner thinks there might be some more needed here. So an inquest is held in an open court environment conducted by a coroner, and the purpose is to gather more information to help resolve outstanding questions about the cause and circumstances of the death. It's really important to mention that an inquest is not a trial. It's not an adversarial environment. The coroner has control of the proceedings, and the coroner is the inquirer and investigator. There are obligations, obviously, to make sure proceedings are conducted fairly, that everybody has a fair say, and that adverse comments are put to others for an opportunity to respond. But as I said, very few coronial investigations proceed to inquest.
To that point,
yeah. There are some matters where a compulsory inquest must be held. So deaths in custody must proceed to an inquest by our state coroner or our deputy state coroner. And in certain circumstances, deaths in care also must proceed to an inquest if, after investigating, a coroner still has concerns about the way in which the person in care, and that's very specially defined, and that's another art in itself, which we won't go into today.
I'm sure.
If there are still concerns about the way that was provided, the coroner might hold an inquest. In other cases, the coroner might just decide to hold an inquest in the public interest, which is a very broad concept. And this might include where there is significant doubt about the cause and circumstances of death. For example, medical cases, which we're talking about, where there is conflicting medical expert opinion. I don't know if anyone has experienced that in this environment. Or the witness evidence doesn't help to resolve for the coroner what happened. And another public interest situation might be to hold an inquest to highlight to the community ways of preventing similar deaths happening again in the future by, the coroner's ability to make recommendations and highlight issues for the community.
That makes sense. Thank you for that. That's been really helpful. So I'm going to fast forward now to talking about findings and recommendations. Fast forward our thinking to the point where the coroner has completed an investigation, and it's now time to sort of move to those next steps. What happens at that point? The investigation's been completed, you've got some findings and you have some recommendations. What happens next?
Well, I think, again, it's really important to bear in mind that the purpose of a coronial investigation is to establish facts. It's not to cast blame or determine civil or criminal liability. That's for other courts and other jurisdictions to manage. However, a coroner can report a matter to the Director of Public Prosecutions or to a professional disciplinary body for their consideration and possible action. And that can happen anytime. It can happen during the investigation or after the investigation is finalised or after an inquest has been held. If the death occurred in a hospital, a copy of the findings is usually provided to that hospital as well as to the department through the Patient Safety and Quality area of Queensland Health. As you've mentioned, and we've talked several times, the coroner can make recommendations about matters connected with the death, for example, mainly to prevent similar deaths from happening again. While there's no obligation on a subject agency to accept or implement coronial recommendations, government does keep the public updated about each agency's response to those coronial recommendations that are directed to the public sector, and that's coordinated by the Department of Justice and Attorney General.
So we've in the the conversation that we've had so far, there's responsibilities clearly for Queensland Health as the agency in this case, who have roles and responsibilities from the beginning of the process through to the end. So, for example, hospital and health services, they clearly have an obligation to report reportable deaths to the coroner. They also assist in coronial investigations by providing information. They might also be asked to appear at inquests to provide in the provision of that information. And of course, they have a key role in responding and implementing the recommendations that the coroner might direct towards a hospital and health service. The Department of Health also has responsibilities in this space. Many recommendations are directed to the department for statewide implementation as opposed to a specific hospital and health service, as you know. So the department and through the Patient Safety and Quality Service plays a key role in that. And our role really is around the statewide perspective and playing a coordination role in the implementation of statewide recommendations, but also in that government reporting process that you talked about. So every 6 months we connect with the lead groups who are looking at recommendations and we work with them to provide an update every 6 months. That works through the Department of Justice and Attorney General and that information is made available to the public. So there's a process also that happens within the department to help provide that information to families. So, yeah, it's interesting and how interwoven it all is.
Yeah, and I think on that point too, the coroner's website where you find you can Google again for where coroner's findings are stored, and there's usually a table where the findings are all listed out, and next to it whether or not a government response was required as a part of that of those findings. Something I didn't mention before as well in talking about hospital systems and lessons learned that might come out of a coronial inquiry. Going back to whether there's an inquest or an investigation behind the scenes, it is possible also for coroners to publish findings from their investigations without going to an inquest. Mm-hmm. And I think I didn't explain before where the terminology of non-inquest findings are published for the broader community to highlight lessons learned or that might have broader application across the system. Usually in those situations there'd be consent from the family, the hospital would be involved or individuals would be involved, and we'd be identifying locations and names and identifiable features of that, because the focus being on those systemic learnings.
That's right. Yeah, excellent. Thank you. And I don't want to end our time today, Coroner Fairweather, without bringing us back to what's really important and central to all of this process, which is around families and communities. And I was just wondering if you had any final words around the impact of the coronial management process on families and communities.
I think we can sum that up by saying that the coroner's investigations are important for families because number one, they provide information. Coroners investigate deaths to determine the identity of the person, cause and circumstances of their death, and they provide regular updates and engagement with family. We also can liaise with families about their concerns and help facilitate conversations with their health practitioners when they do have concerns. We identify support services, so coroners can help families connect with social workers, counselling and other support services, including community legal centres if they feel legal advice is needed. But, I really want to highlight that we have our forensic counselling services, which I regularly employ to help me liaise with families to help them understand what I'm doing and why I'm doing what I'm doing, or what other information they might have about their loved one that can inform us and help us make better findings.
Yeah, so important.
Yeah, it really is. And obviously we've talked about it, the focus on being able to have a voice to prevent deaths similarly occurring again in the future by identifying systemic issues and hopefully useful recommendations that can be employed across the system to prevent things from happening again and highlighting issues for the community.
Yep. Look, it's been an absolute privilege to talk to you today, Coroner Fairweather. It's been a fascinating conversation, and I feel like we've covered off quite a broad range of topics in a really high overview, though, around coronial management in Queensland. Thank you so much for your time.
Thank you, Melleesa.
And that draws us to a close on this episode. For more information, you can go online to both the Queensland Health and the Coroners Court of Queensland websites. Thanks for listening.